Hello everyone, you're all very welcome to the first installment of our 2025 GP webinar. If you bear with me for a second till I start my video. Hopefully everyone can see me now. You're all very welcome. So this is the first in our 2025 GP webinar series, where this evening we're going to be exploring the topic of deliberate self-harm. We're joined this evening by Dr. Kevin O'Hanrahan, a senior clinical psychologist here in St. Patrick's Mental Health Services, who will present an overview of deliberate self-harm and discuss ways in which this can be addressed in the GP surgery. ICGP CPD certificates will automatically be sent within the next 4 weeks to any GP who is registered and is attending live this evening. There'll be an opportunity following the presentation for a short Q&A, and you can submit your questions via the Q&A function on your screens throughout the webinar. So we'll go ahead and get started. I'm going to hand you over to Dr. Kevin O'Hanrahan. Welcome, Kevin, and thanks for your time this evening. So whenever you're ready, Kevin, you can unmute.
Great, thanks, Amanda. Hi, everyone. We'll jump straight into it. So as Amanda has said there, there's two main focuses today, right? So there is the focusing on kind of understanding self-harm. So kind of understanding some of the most recent research with it, as well as trying to understand it from a patient perspective. And then I think probably more importantly for you guys is how to respond to it when it shows up in the GP surgery, and what you can do in what is a really limited amount of time when that comes up. We'll have time at the end for questions as well. So anything that kind of comes up, make a note of it, and I'll try and leave a little bit of space at the end for that. So in order to start thinking about it, I've got three fictional examples here, right? So we've got Tara. So a 17-year-old girl presented to the surgery accompanied by her mom. The mom has recently discovered that she's been burning herself and is really concerned. And Tara is very ambivalent about stopping self-harm. And we've got John, 23-year-old man, presenting to the surgery with stomach complaints, with a background history of anxiety. And during the assessment, you notice several horizontal marks on his upper thighs. And Noreen, a 46-year-old woman with no prior history of alcohol dependence, reports a recent recurring pattern of consuming a 700ml bottle of vodka following arguments with her partner. So we're going to hold these three people in mind as we kind of talk through what is self-harm and what that person, or why that person might be engaging in this behavior and what function it might be serving. So we'll kind of keep coming back to them. So there's kind of an ongoing discussion about what self-harm is and how it's best defined. But I think in order to simplify it, we'll kind of go with the definition that we use in the DBT program in St. Pat's, which is the American Psychiatric Association definition. So the intentional direct destruction of body tissue. It's kind of short and snappy, and I think that's one of the reasons why we like it. And here are what we typically see as examples of deliberate self-harm. So typical things are things like cutting, burning, banging head, picking skin. The definition is a really, really important one, that it's intentional tissue damage. So if we think back to Noreen's example, so Noreen is definitely drinking a harmful amount of alcohol. That's definitely true. Her health is being harmed by it. Whether it's deliberate self-harm really depends on what Noreen is trying to do there. Right? So is Noreen doing it so that she intentionally damages her liver? If she is, then we're probably talking about deliberate self-harm. If she isn't, and she's using it more as to kind of numb the pain or for other reasons, that's probably not best understood as self-harm. So the behavior is important, but the person's intention and their function is really important as well. The other thing that I suppose is also really important to think about is that sometimes self-harm is really visible, but I think more often than that, people hide their self-harm. Right, so John's example, who's the guy who you discover has the marks on his leg when you're doing a stomach examination, that's quite a typical example, really, of self-harm. Most people actually do try and hide it, and it's more kind of hidden and concealed. So it's not always immediately clear that somebody is self-harming. So in terms of who tends to present with self-harm, so typically it's women, kind of young women, 15 to 19, and males 20 to 24. And then in terms of the rates of it, the rates they're kind of striking. Every time I see them, I'm kind of struck by them. So 1 in 5 adolescents, and 1 in 8 young adults, and 1 in 16 adults. The research is kind of saying at the minute that amongst adolescents, it's not necessarily increasing. It's not that more young people are self-harming, but that the pattern is changing. So what it looks like is that maybe males might be self-harming a little less frequently than previously. And it's on the slight increase in terms of females, but what potentially is more concerning is that amongst young adolescent females who are self-harming, the intensity and the frequency of that self-harm is what's increasing. So there's definitely going to cause for concern there. And in general, in adult males, the rates of self-harm are increasing as well. So this is clearly a real problem. I guess that's why we're all here today. So it is the problem, and it's not the problem. Actually, it's the solution. Right? So if you take one thing home from today, it's this idea that for the person who's self-harming, self-harm actually isn't the problem. Self-harm is that person's solution to what the problem actually is. Right? So the problem, whatever is kind of going on for that person, self-harm is that person's way of coping with it. So kind of reconceptualizing it that actually, of course, we want people to stop self-harming, and it's not actually what the problem is. Something else is driving that behavior. And so if you ask people and ask them in a kind of a non-judgmental and a curious way, what is it that you get out of self-harm? You get a range of different reasons. Right? And as different as like to not feel and to feel something. To cope with dissociation, which is that kind of feeling of losing grip of reality or that things are starting to feel not like they're not real. To cope with unbearable pain, or to translate emotional pain into physical pain. As a form of self-punishment, which is a really, really common reason among young people in particular. And sometimes as a form of suicide rehearsal or preparation. So there are loads of reasons why people are self-harming. And I think understanding that is a really, really key part of understanding what's going on for somebody who's self-harming. I think here is probably a useful place to explore some of the kind of misconceptions or beliefs around self-harm. That self-harm is always about kind of looking for attention or kind of, like manipulation or things like that. It is true that sometimes some people self-harm for those reasons, but actually, if you look at the research, it's really, really low down on the reasons that people endorse for self-harming. That actually there are interpersonal and intrapersonal reasons, but the intrapersonal reasons are always rated higher amongst any kind of research. That actually this isn't really about other people. It's about what's going on for them. It's why people like John are hiding their self-harm. Actually, it's not about what other people, it's not about for other people. It's for them. So if we think about what some of the things are that are going on for people who present with self-harm. So this was a multi-site study carried out across the UK by Ellen Townsend. And what we can see there, and why I kind of put it in there, is that there are a multitude of reasons for people engaging in self-harm. And that actually not all of them are complex mental health problems. So it's not always people who have a diagnosis like borderline personality disorder or bipolar affective disorder or major depressive disorder. It might not be a complex mental health problem that's driving this behavior that they're using self-harm to cope with. So asking around these things can be really, really important when someone is engaging with self-harm. Now, obviously, not everyone who's having difficulties in their relationships or difficulties with employment are engaging in self-harm. So how do we understand why some people are engaging in self-harm when that happens and some people aren't? So one really important lens to think about that is emotion dysregulation. So, and this is how, so I work on the DBT program, which is for adults, and I work on a DBT informed program for adolescents. And when I'm describe an emotion dysregulation, I'll always talk them through it exactly like this. So for some people, something will happen, right? So say they'll have an argument with their mom, or they won't get invited to the party in school, or they'll get cut off in traffic if it's an adult. And the thing will happen, and the emotion will go up. It'll stay up for a little while, and then it'll come down relatively quickly. But for other people, the same thing will happen. But they're operating at a higher level of intensity anyway at baseline. And for a load of reasons, none of which are their fault, their emotion ramps up really, really quickly to a really, really high level of intensity. And it will stay up for a really, really long time and take a really long time to come back down to baseline. And if you talk to people who have this kind of a pattern and you present those two lines and then say, does this sound like you? Does this sound familiar? It is amazing how many people will be like, yes, that is me. That's what my experience feels like. Other people don't get it. But when I get really upset or I get really sad or really angry or anxious, it's like it's the end of the world. And other people have noticed it about me too. So there's something really powerful about being able to share that with people of like, yeah, this is real for you. And then I'll continue, right? The problem is you could draw an arbitrary line round about here. And anything above that line, you can call the red zone. So the red zone is where your emotions are so high and at such a high level of intensity that you can't think straight. Right? Your nervous system is on fire. You've got adrenaline, you've got cortisol pumping around you. Everything feels really quick and really, really urgent, and it's awful. You talk to people who have this experience, and it is horrendous. Right? It's really, really awful. And an important thing to think about is that what people are experiencing here, this level of distress, if they've got emotion dysregulation difficulties, which are those three things that I talked about. So sensitivity, they're kind of easily triggered. Intensity, it's really, really high level of intensity and a slow return to baseline. So people who have that kind of a pattern, they're experiencing levels of distress multiple times a day that other people might never, ever experience. They might never experience this level of emotion. Or if they do, it's a couple of times across their lifetime and they'll remember it. Right? So for these people, they're experiencing it every day, multiple times a day. And the thing is when you're in the height of it, like when you're around about here on the graph, you don't see the graph. You can't see that this is going to end at some point. It feels like this is never going to end. I'm always going to feel like this. I'm always going to be in absolute hell. So it's been described, emotion dysregulation has been described by some DBT researchers as that these people are like, they're like emotional burn victims. Right? It's like they don't have the protective barrier of skin on their hand. So if you imagine what that's like, the first person, right, who has their protective barrier of skin, they grab a nettle. Oh, really, really sore, really, really intense experience, but it goes and it's okay. Now imagine grasping that nettle with no skin on your hand. That's what these people are experiencing. And so the question I want you to consider is, if that was your experience and you were in that feeling of absolute hell and you'd no way out of it, you'd no way of knowing if it was ever going to end, and you'd no other way of coping with it, and you found this one thing, and this one thing works, it works really, really quickly, and it works pretty much every time. Wouldn't you do it? Wouldn't you at least consider it? I think I probably would. And that's what self-harm is for some people. It is their only way out of hell. It is their only way to cope with this incredibly intense emotional experience. And what I really like about DBT and how we work is it comes from that standpoint of like, this makes sense that you're doing this. The other side of the dialectic, so the D in DBT is for dialectics. The other side of the dialectic is, of course, we want people to stop self-harming. Of course we do. And at the same time, it's totally understandable that if they found one thing that works, that they're holding on to it. Right? So it's like an analogy of a shipwreck survivor. Right? And if the ship has been blown apart and they're hanging on for dear life in the middle of a stormy sea to a piece of debris, and you're standing on the shore and you can see them, and you know that that if they keep holding on to that piece of debris, eventually they're going to die. Eventually they're going to drown. So you want them to let go of that piece of debris so you can get them safe. But for the person who's in the middle of it, who can't swim, who is clinging desperately onto that piece of wood, of course they don't want to let it go. Of course they're terrified to let it go, and actually screaming at them to let go of the one thing that's keeping them alive now, so that they're still alive in 20 minutes. They're not going to do it. So people have to be kind of given alternative ways of coping with it in order to give it up. So coming from that standpoint of like, it makes sense that you're doing this, and at the same time, of course, we want to help you find different ways of doing it. So in terms of thinking about how you guys can respond when this shows up in the GP surgery, and I guess the other take-home message is to be realistic with yourselves, right? So the person's reason for self-harming might be really complex, right? As we've talked about there's multiple reasons for that people self-harm, and it differs across people, but it differs within the same person. Some people will self-harm in different ways for different reasons, or the function will change from week to week. So it's probably quite a complex set of reasons that they are self-harming. They've also likely been doing it for a while, right? So it's probably unlikely that the first time someone self-harms, they present to a GP. It's likely that it's been kind of going on for a while, and it's hit some kind of a crisis point, or they've been found out, or something has happened which has made them come here, right? But it's not likely to be a hugely new behavior. And like I said, they might have no better way of coping. And as a result, they might be ambivalent or unwilling to stop. So the example of Tara, the 17-year-old who was discovered by her mom, that's quite a common enough, I would imagine, presentation that comes into GP surgery. Actually, the parent is desperate for this behavior to stop. Of course they are. And the young person is unwilling to stop, because it's their only way of coping. And you have 15 minutes. Right? So if you have 15 minutes, how much are you really going to be able to do in that time? Standard like as a counterpoint, a standard DBT program, which is the best evidence-based therapy for stopping or reducing self-harm, standard DBT program runs for 12 months. Weekly individual sessions that last an hour, and weekly group sessions that last for 2 to 3 hours. So that works. We know that works. There's randomized controlled trials and there's all types of research. But look how much time that takes. So if you've got 15 minutes, it's going to be about, okay, what can I do in this short amount of time? And the positive news is that there is definitely things that you can do. However, stopping the self-harm is probably an unlikely aim in that amount of time. But you can absolutely start. You can absolutely start that journey. So the first piece of advice is to use a DBT skill, but for you guys to use it. Right? So this is a distress tolerance skill from DBT. And so distress tolerance is the set of skills that we teach people to use when they're in the red zone. Okay, so you think about what's happening in your surgery when a self-harm disclosure is made. Again, we'll take Tara as the example, the 17-year-old girl. So she's bringing loads of emotion. She's probably bringing a heap of fear, a heap of anxiety, probably loads of shame, because this behavior she's been trying to hide has now been like discovered, and she's having to tell someone else about it, or her mom is telling about it. So she's bringing loads of shame. The mom is probably absolutely terrified, is probably having loads of like really scary thoughts about how her daughter is going to be, and self-harm and suicide. And she's probably maybe also kind of angry, and that's kind of coming out as well. And then you've got your own emotions. So who knows what's kind of gone on in the surgery that day, and what else you've seen, as well as kind of what's going on in your own life. So there's loads of emotions coming around, and then you've got that ticking clock of like, we've got 15 minutes. So the stop scale might be a really helpful thing to do here, and it takes around about 10 seconds to do. So what we want to do is kind of follow the steps there. So the first thing is to stop, take a deep breath, then observe what's happening internally and externally. So basically, what am I feeling, right? And what can I notice about the other person? Possibly what you might be feeling inside, which is a really understandable feeling and urge to have, because everyone who gets into healthcare gets there because they want to help people. There's probably going to be a really, really strong urge to fix this, right? Because that's kind of what we are, what we do. So you might even just kind of notice that urge to kind of jump in and fix it. And then step 4 then is going to be about proceeding effectively. So what that will look like, probably for the person in front of you, is how do I get into the right here and now? And how do I get in contact with this person and listen to what they're telling me? You've only got 15 minutes. You're not going to be able to fix this problem, but you are going to be able to connect with them and hear what, and really kind of hear what they're saying, and then kind of start thinking about what might be kind of useful solutions. And potentially, the first proceed effectively thing you might do might be asking the question. So if we think about John, who you've discovered kind of horizontal marks on, we don't know that that's self-harm, right? Clinical intuition would tell us it's very likely to be self-harm. We don't know until we ask the question. And what's really important, as well as asking the question, that's the first thing, right? And I think there used to be a lot of worries that if you ask someone about self-harm, or if you ask someone about suicide, you'll be kind of putting the idea into their head. And no piece of research has ever found that. No research has ever backed that up, right? If we're talking about young people and self-harm, if you have worries about self-harm and you ask about it, you're obviously not going to be the first person that young person has heard talk about self-harm. They know it's there. It's likely their friends have done it or are doing it, or they've seen it somewhere. Same with suicide, right? So asking the question is almost always a helpful thing to do. There's no iatrogenic effects to ask the question. And how we ask the question is really, really important. So these kind of examples of invites no and invites yes responses are from a study done recently from A&E in England, right? So what they did is they videotaped real risk assessments, and they examined the type of questions that people were asked and how they responded to them. So the first thing that they found was that open-ended questions tended to get better information than closed-ended questions, which I think probably kind of most people will kind of intuitively know. However, they also coded the types of closed questions that were asked. So ones that invite a no response, so they use words like never, ever, always. They use kind of more like polarity extreme language. And the invite yes response are kind of a bit more general. And what they found is that if you ask a no leading question, you get a no response 92% of the time. Which I think is like, that is a huge number. These are people who are having risk assessments done in A&E. They're not being done for the crack. Like, there's a reason why these people are being asked these questions. So for only 8% of the time to be a yes shows me that there's something else kind of happening there. Conversely, if you ask a yes leading question, you get a yes response 65% of the time, which sounds to me more about what you might expect when you're doing the risk assessment. So absolutely asking the question is important, but how you ask it is also really, really important. This might be the first time this person has been asked this question, and they might not want to be saying yes. Right? So it can be about just, how do I ask this in as open and curious and non-judgmental way as I can. A word on the link or the links between self-harm and suicide. So self-harm increases the risk of suicide. So people who self-harm are much more likely to die by suicide than those who don't. by somewhere in the region of 50 to 150 times, they're more likely to die by suicide. And there are loads of kind of reasons behind that we don't have time to get into, but that does indicate that when self-harm does come up, you need to be concerned about suicide. And at the same time, not all people who self-harm want to die by suicide, or even will experience suicidal ideation or make a suicide attempt. So some people will be self-harming for years and will never have any intent to die. That's not the function of their behavior. Their function is actually to cope with the pain. And for some people, and I work with people like this, they're saying that actually I'm self-harming so I don't kill myself. That actually this helps me cope. And if I don't have that, then I don't know, then I don't know how to cope. And I don't know if I can kind of stick around for that. So the top tip here, and this is a DBT principle, is assess, don't assume. So it's really important not to assume that someone with self-harm has suicidality, but it's also really important to not assume that they don't. So again, it comes back to ask that question. And it doesn't have to be done in any kind of a complicated way. It can be as simple as like, it looks like you're in an awful lot of pain. Have you had thoughts about killing yourself? Have you had thoughts about taking your own life? So asking the question is probably the most important thing there. The next thing that you can do is validate. So we talk a lot about validation. There's a lot of talk about validation and invalidation, and it's on social media an awful lot of the time. What it actually means is the communication from one person to another that what you are seeing or doing or feeling makes sense to me. So in some ways, it's a really simple idea, and it's a really powerful thing for someone to hear. So what you're doing makes sense to me. So as I said, I work on the DBT-informed program called PSGA in PATS, where parents and young people are present. And we spend a whole session teaching parents how to validate their young people, teaching young people how to validate themselves, and validate their peers. Because I think, again, this is something we talk an awful lot about, but actually very few people have had it broken down of like, how do I actually do that? And again, if you've only got 15 minutes, this is definitely something that you can try and get into that time. So this is a worksheet done by Alan Frizzetti, who's done an awful lot of work on DBT and validation in particular. And so I really like this because it's kind of broken it down into steps. Right? So you've got your stock phrase, which is I know that, or I can see that, or it makes sense that. Then you've got add a verb, and then what you're trying to validate. So I know that you feel in a huge amount of pain. I can see that you want this to end, that you want to find a way to stop this. It makes sense that you think that the best way to do this is to self-harm because you've never been told any other way, or you've never learned any other way. So this is a really, really helpful thing that you can do that communicates that what you're doing on some level makes sense. Now, there's a couple of really important principles to this. Another one, and another take home, this is your third take home. When you do that, so when you work really, really hard to validate, right? So I know that you're in a lot of pain. Don't, and it's really understandable, and everyone makes this mistake, and we usually spend loads of time in group talking about it. Don't follow that sentence up with a but. And the reason is, if you listen to the difference of how these messages sound and how they would land with someone. I know that you're in a lot of pain, but there are other ways of coping. Versus, I know that you're in a lot of pain, and at the same time, there are other ways of coping. It hits totally different because the but negates the first part of the sentence. Right? People don't actually hear the first bit anymore because they go, oh yeah, they've said that, but actually what they really want me to hear is that I just need to cop on. I just need to cope better. That little phrase, and at the same time, If you can remember that in the context of trying to validate, it means that the message gets heard. And really importantly, it means you can hold both sides. Because what some people's reservations around validation or concerns around validation are like, does that mean that I'm condoning the behavior? Does that mean that I'm saying it's like, by saying that it's understandable, am I saying that I'm some way in approval of it, or saying that it's an okay thing to do? And the short answer to that is no. So the principle here is validate the valid. So try and ask yourself, well, what is valid about what the person is doing or feeling or thinking? Why does it make sense? And things you might think about there are things like their current difficulties, their lack of alternative coping skills, their historical context, the relationship between emotion dysregulation and therefore self-harm and trauma is well documented. So if you know that as maybe the family GP, you know that you can validate at that level. Or their previous learning. Where have they learned this from? Or where have they not learned coping skills from? So you can validate all that stuff while not looking to validate what's not valid. So you're not saying this behavior is fine, keep on doing this. You're holding both sides. It makes sense that this is your best way of coping right now. And at the same time, let's try and find you other ways of doing it. If we think about this principle and really kind of extend it, say I have a really tough day in work and I come out of my office and I put a brick through my colleague's window. Even the most validating and kind and compassionate psychology manager is not going to tell me that it's okay to put a brick through the window. They might work really hard to validate that, like, oh, you sound like you were really, really frustrated there. Sound like you've had a really, really bad day. And at the same time, you put a brick through John's window, so we are going to call in the guards. Right? So you are not validating, you're not condoning the behavior, but you are validating the person's reasons for doing it. You're trying to understand it. Now, importantly, this has been empirically measured. And I think that that is a really, really important thing, because otherwise this can sound a little bit fluffy, it can sound a little bit lovey-dovey, and thankfully it's not, because it's been empirically studied, right? So Alan Frazzetti, who I mentioned there, and his colleague Chad Schenk have explored this. Right? So this is from a study where they gave people a difficult maths problem. And at different times during it, half the group were given validating statements, like, this is really, really hard. Loads of people are struggling with this. I struggle with maths problems too. And the other group were given invalidating statements. Things like, don't know why you're finding this so hard. Everyone else is finding this easy. You're really getting a little bit too worked up about this. And then they asked people, or they tracked people at those various different time points. How do you feel, right? This is a negative affect scale. So higher scores indicate like higher levels of distress. And we can see the difference there. Those that were invalidated felt a good bit worse than those who felt validated. So subjectively, people reported they felt worse. But really importantly, and probably very importantly, talking to a group of medics, they also looked at heart rate. Right? So if you think of the emotions that are going on at that time for those people, it's probably things like anger and anxiety, both of which are going to increase your heart rate. And if you look at what the results are, there is a very clear difference that actually people who were validated, their distress went down as measured by this. Those who were invalidated, their distress went up. And then for good measure, they also looked at skin conductance. And again, what they found is a clinically significant difference, or statistically significant difference, between those that were validated and those that were invalidated. So what's really useful about this is that you can do something in that short period of time, which is actually going to bring down the stress without necessarily looking to change the behavior in that short period of time. You can still bring down that level of distress. It's a really, really, or I think a really, really important finding to bear in mind. Another thing that you can do is to try and develop an understanding of the self-harm behavior. So all behavior is caused, right? And all behavior is influenced by, like, two large scale factors, generally antecedents, things that happen before the behavior, and consequence, things that happen after the behavior. Right? So in order for behavior to keep happening, something either before or after, or potentially both, must be happening to keep it going. So in terms of antecedents, we're kind of asking, so if we focus on one specific incident, and that's really important if you're going to kind of do this, is focus on one incident. So you cut yourself last night. Okay, tell me about what was happening before. What made you vulnerable? And sometimes it'll be one big thing. It'll be really kind of clear this thing happened. Or other times it might be loads of kind of small things, and then there's like a straw that broke the camel's back. So what happened beforehand? Right? You've got what the behavior is. They told you that, they cut themselves. And then the consequence is, okay, what happened afterwards? And the key here with consequence is ask and focus on the short-term consequences. Right? When you ask that question, people will often say things like, I felt really guilty about it later on, and I felt really, really terrible about it today. I'm not all that interested in that in terms of understanding the behavior. What I'm interested in is what happened straight after you cut yourself. Right? Did the sadness that you felt go down, or did the anxiety go down, or did you finally feel something, or did you stop dissociating? They're what I want to know about, right? Because in order for behavior to keep happening, there must be something rewarding about it. And the thing is about human behavior is that like we are much more influenced by the short-term consequences, which are often positive, than the long-term consequences, which are often negative. Right? So if you imagine it's 12 o'clock at night and you're in work in the morning and you've just finished watching an episode on Netflix, and Netflix cue the next one, and you go, oh, I really should go to bed, but it's so good and it's season finale. Oh, I'm going to watch it. And so you let it roll and you go, oh, this is great. I really enjoy this. The next day you're exhausted and you spend the whole day telling yourself you're never going to do that again. I can't believe I did that. Actually, the next time Netflix cues the next episode at 12 o'clock, you're more likely to watch it than you were previously, because the short-term consequence was positive, and that has a bigger influence on your behavior. So what this might look like for someone might be, so you focus on the behavior first. So what was the behavior? So I cut my leg 5 times with a blade. And try and be as specific as that. Okay. What was going on beforehand? So I wasn't invited to a party. I felt sad and I felt embarrassed. Okay. What happened afterwards? I felt less sad. I was distracted, and I was distracted when thinking about the party. You've now got a really good understanding of what happened. And really importantly, your patient might now have a better understanding of like, all right, this is why I keep doing it. Right? I'm being positively reinforced by the behavior, in that like I feel good emotions after it. And there's negative reinforcement, which means the negative emotion is being taken away. I feel less sad. So when you do this, and you can do this in a validating way, your patient's understanding of their own behavior increases, as well as your understanding of their behavior. Right? And again, that's something that can be done fairly quickly, and holding that like ABC model in mind. The other thing I was thinking might come up in the GP surgery is, how do I help parents? Say if a parent comes, and maybe in the absence of the child, or with their child there, but the parent kind of comes, but like, what do I do about this? Right? And so I link to a couple of really useful resources that I've kind of taken some of these ideas from. But to boil the main thinking down, there's a kind of a list of don't, do's, and it depends. Right? The first don't is, don't punish the behavior. It is totally understandable that as a parent, you want this behavior to stop. Of course you do, right? And as a parent, and I'm one myself, we've used punishment, right? So it is totally understandable that you would react in this way in their highly emotional state to punish the behavior. The fact is, it doesn't work. It doesn't work. What it'll actually likely do is push the behavior more underground. So you found out about this behavior, by punishing it, it's possible that the young person becomes even more secretive about their self-harm, which is a couple of risks. One of which is that if you really force somebody to hide their self-harm, they'll start self-harming in more and more intimate areas that they don't get found out, which is obviously really negative consequences. So punishment doesn't work. Same with no self-harm contracts. They don't work. Right? There's no evidence to suggest they work. It's the same with no suicide contracts. They've never been shown to work. Again, it's really understandable that people bring them in, but they don't work. Try not to express anger towards your child. I've worded that really deliberately. Don't express anger towards your child. Right? You can't tell somebody what to feel when they discover this thing that they never wanted to discover about their kid. Right? So it's not about don't feel angry. Of course you might feel angry. Right? The harm is being done to somebody that you love. That's one of our evolutionary reasons why we have anger. Right? So of course you feel angry. And try not to express the anger towards your child, because it will be felt like blaming. And then try in as much as you can to not let self-harm be the sole focus of your relationship with your child. Again, here's the dialectic. Of course, it's going to be a focus. Of course, it's going to be a topic of conversation more than it was before. Of course, you're going to be probably thinking about it all the time. And at the same time, try not to make it the only thing that the relationship is about. Because your child is still your child. They're coping with awful things and they're coping with it in a way that you don't like or agree with. But you're still your child. There's still other things going on that you can hold in mind while holding the self-harm. Do try and ask in a non-judgmental, curious tone if you're concerned. Right? So that can be things like, I notice you've some cuts in your arm. Can you tell me what's happening for you? Or if you need to be more direct, I can see you're really upset right now and you've been wearing long sleeves, even though it's really warm outside. Have you been hurting yourself? So you're encouraging them to ask the question in an open, non-judgmental and curious way, and kind of grounding it in like, here's what I'm noticing about you. I'm noticing that your behavior has changed, or noticing that your mood has gone down. Take any talk of suicide seriously. We've talked about the relationship between self-harm and suicide. If they're talking about suicide, take that really, really seriously. Validate the distress. So the stuff that we've kind of talked about how you validate exactly that. Validate your child that this makes sense that you're in this much pain. You're being really, really badly bullied. School is really, really, really stressful. Me and your mom have broken up. Whatever it is that's going on, you're validating the stress. Express your concern. So while you're trying not to express your anger, it is totally okay and probably helpful to express that you're concerned about your young person. Right? That's probably quite a helpful and validating thing for them to hear, that actually this person cares enough to be concerned. Try and remember that recovery means different things for different people. Right? So reducing self-harm is important. Of course it is. And at the same time, someone can reduce how much of self-harming and still be absolutely miserable. So recovery should include things that are important for your young person. So maybe that's different goals or engaging in meaningful activities. If the person is in treatment, or they're reducing or stopping self-harm, expect and plan for lapses. Lapses happen, and knowing that and expecting it and planning for it. So, hey, if this happens, can you tell me about it? Can you let me know if you do self-harm again, so that we can kind of put a plan in place? And that's what's going to stop a lapse becoming a relapse. And I cannot highlight this enough. And I'm sure this is stuff that you're saying to your patients anyway, but seeking out their own support is so, so important. For some people, that would be therapy. For other people, it would be talking to a friend that they really, really trust and who can keep this confidential. But like what they're going through is really, really awful. And at the same time, they're trying to support their young person. So getting them to seek out support for themselves. That analogy of putting on your own putting on your own oxygen mask first really, really stands here. you're going through really, really hard times. Get the support that you need as well, so that you can support your young person. It depends are two fairly controversial ones. So the removal of sharp objects, and probably more controversially, body checks. And they fall in the it depends because it really depends on what the young person wants or would find helpful. So in the absence of very serious suicide risk, removal, like, first of all, removing sharp objects, it does reduce the likelihood of self-harm. A lot of self-harm is quite impulsive, right? And people are less likely to self-harm when the thing they've been self-harming isn't immediately there. We know that. And at the same time, if someone wants to self-harm, they really, really want to self-harm and they're in enough distress, they'll find something. It's impossible to hide every sharp object. So for that reason, if the young person thinks it would be helpful if you took these things away, brilliant, go and do it. But doing it against their will is likely to be unhelpful and ineffective. And it's the same with body checks. So for some young people, they want that, right? There's something about the kind of accountability of like, look, I know mom is going to be checking my arm or my leg. And that can kind of be the thing in the moment that says, oh, look, I'm not going to do it. I'll do something else. So if they think it will be helpful, then I would say go and do it and be really clear about what the rules and the boundaries are around it. But again, if they don't think it will be helpful, it becomes just another unhelpful part of the dynamic, right? And then you're potentially kind of violating someone's privacy, their bodily autonomy, and again, there's the danger that it just goes underground and becomes even kind of more serious. So they're not two things that I would they're not things that I recommend at all, unless the young person is kind of saying, look, I think that this might be helpful. Can we try and work a way to do it? And then finally, you're going to be kind of signposting, right? So pointing people in the right direction for help. So there's some interesting research that says that, like, when people disclose self-harm, how negative or how positive the experience of disclosure is doesn't actually immediately impact self-harm one way or the other. But what it does do is it influences the next thing that the person does. So how well they engage, or how likely they are to make another disclosure to another health professional, or how likely they are to engage with another service. Right? So again, you're not going to be able to stop or reduce the behavior probably in that time, but you can really impact the direction of the journey. So these are some really useful resources, right? They're useful for patients, they're useful for parents, they're useful for professionals as well. A couple of kind of shout outs. This podcast, The Psychology of Self-Injury, is really, really good. A lot of the ideas that we've talked about today, I've kind of taken from ones there. And there's really ones that are specific for parents, specific for people who are helping people with self-harm. Really, really, really good. This is the Coping with Self-Harm brochure for parents. This is the one we talked about earlier, which I took some of the do's and don'ts from. Really, really good. The link is there. It's like 13 pages. Really, really great resource for parents. And this Battle Scars app is also a really, really helpful one. There's a lot of kind of lived experience stuff there, what people are going through, how they can best be supported, that kind of thing. There's obviously kind of referral. So there is a link there to the HSC DBT programs. There's also obviously ourselves, and the link is there for referrals. We've got the DBT program in St. Pat's, and we've also got the DBT Informed program for adolescents, which we've had open to GP referrals for a little while. So I think Katie is going to put a link in the chat box, or just a couple of questions in the chat box. So if that's something you want more information on, just please do fill it out, leave your contact details, and we'll be in touch. It's a 22-week program. It's covered by health insurance. And I mean, I'm biased because I'm the clinical lead on it, but it's really, really good. So that's also something to consider. And then there's other services as well. So things like Aware, there's the HSC Family Connections program, which is really helpful for it's so designed for members of client or family members of clients with BPD, but anyone who's going through DBT or has emotional dysregulation, it would be helpful for. And the SPACE program, and that's in Temple Street, is also really useful. So we're nearly done, and you've heard an awful lot of me, but I want the last word of this to be of somebody with lived experience of self-harm. So the following is a quote from a young person who participated in a study last year about their experience of disclosing self-harm and what they needed out of the experience. So as you can see, that the main thing that they needed was to be seen, heard, and understood. So I'll leave you with that to think about. I think we've a little bit of time for questions if anyone has one.
Thank you so much, Dr. Hanrahan. Again, my video is having a little bit of difficulty. I'm there. So thank you so much for that comprehensive presentation. We do have a couple of minutes for a short Q&A if anyone would like to add a question to the Q&A box. We do have a couple of minutes. In the meantime, though, we did actually have an email come into the communications inbox, if you're happy to answer that, Dr. Hanrahan.
Yeah.
Okay, so this person asked, how should GPs assess the risk of escalation from self-harm to suicide?
Yeah, I think it's a really, really good question. And I think it boils down to asking the question. I think so, yeah, there is definitely a link between self-harm and suicide, not for everyone. So absolutely asking the question is a really helpful thing to do. And then I think you're kind of asking the questions that you might be asking anyway. So things like, what's the level of, so if you're thinking about wanting to be here, is that like what's called a passive death wish of I would rather that I wasn't here, or is there something kind of more active, like I want to end my life? And then you're kind of asking questions like, what's the level of intent? So is it kind of more passive, or is it something that I really, that I want to do? Is there active planning? So am I planning to do this? And what's the details of that plan, and how doable is that plan? And then what's the access to means? Right? So if the person is thinking about taking an overdose and they have a load of medication, then your risk of the risk of suicide is obviously going up, because oftentimes self-harm or suicide is a really impulsive act. So they would probably be the questions I'd ask, but I'd come back to the most important thing is asking the question.
Thank you. I don't think we have any other questions in the Q&A box, so we might leave it there if that's okay.
Perfect. Great. And just a shout out again about those kind of questions. If people do want more information about the program, absolutely just let us know and we'll be in touch as soon as we can. Perfect.
Thank you so much, Dr. Hanrahan. So thanks everyone so much for joining us this evening. We hope you found it really useful. So when we sign off from this evening's event, you're going to see a link appear on your screen where you can share feedback, and we'd really appreciate if you could put in your thoughts, and just for helping us to improve future events. So if you have 2 minutes, please do follow the link and share your feedback. And lastly then, CPD points from the ICGP are available to any GPs who have attended this evening's event, and this will be sent to you automatically over the next 4 weeks. And a recording of this webinar will also be made available at stpatricks.ie/GP referrals. So thank you all so much, and good night.